Assalamu alaikum wa rahmatullahi wa barakatuh. I am Dr. Sabir Sarafandi. Today, inshallah, we'll speak about how to examine the respiratory system as a bridging course for fourth year medical student. First of all, to start with the physical exam, we have to know the topographical landmarks for the chest exam. We have here the mid-sternal line, the line that can cross the middle of the sternum. We have the mid-clavicular line, and we have the anterior axillary line. This line is important for anatomical understanding of the lung and the pleura and the transverse and oblique fissure. In the back we have the vertebral line that cross in the center of the vertebra, and the scapular line and in the middle of the scapular spine. And from the laterally we have the anterior axillary line and the posterior axillary line, and we have in between the mid axillary line. So the lung anatomically lies between these anatomical landmark. We have transverse fissure, we have oblique fissure in the right side, and we have oblique fissure in the left side. The oblique fissure divided the lung into the right upper lobe and right lower lobe. We have also the transverse fissure that divided the right upper lobe from the middle lobe. In the left side we don't have the transverse fissure, we have only oblique fissure that give us the left upper lobe and the left lower lobe. The transverse fissure is coming from the back, started from the back at the level of T3. This is the oblique fissure, the left oblique fissure, and this is the right oblique fissure. It started at the level of T3 and passing anteriorly until the level of the sixth rib at the mid-clavicular line. So we have here the right upper lobe, we have here the right lower lobe. We have also the transverse fissure that started from approximately the fourth rib anteriorly and passing medially, passing laterally to the crossing the oblique fissure at the level of fifth rib at the mid-axillary line. So it divided the right upper lobe and the right middle lobe. So this is the anatomical landmark, while in the left side we don't have only a transverse fissure, we have only oblique fissure that divided the lung left upper lobe and left lower lobe. We have also the lung anteriorly, the lower border at the sixth rib. So when we found the lung in full inspiration and during the even in the chest X-ray, the anteriorly the sixth rib at the level of the sixth rib, posteriorly 9 to 10th rib, 9 to 10th rib posteriorly. Okay, So there is a common questions where do you examine the right for the right middle lobe abnormality? And during auscultation, percussion, you should know that the right middle lobe is represented at the right mid chest anteriorly and laterally between the fourth rib and the sixth rib. So it is not posteriorly. You put your stethoscope posteriorly, this is wrong. We don't examine the middle lobe from the posterior because it's lie from the fourth rib anteriorly until sixth rib anteriorly and the fifth rib at the lateral side. Sternal angle anteriorly, this is anterior sternal angle of angle of Louis, represented the trachea bifurcation. This is the trachea, and the trachea divided into right main bronchus and the left main bronchus. Posteriorly represented at the level of T4. So by general examination to the patient who's having respiratory disease, there is a common encounter. So we can ask the patient, examine this patient respiratory system, or examine this patient chest, or listen to his chest. So we need to know that a systematic approach to the patient. You start generally by general examination, then inspection, then palpation, and percussion, auscultation. Before we start, we have to have essential checklist. Sir, wash hands, introduce yourself, be noticed or be observant, and constant, or take a consent from the patient that you will examine him, will expose and reposition the patient at a level of 45 degree. You should inform the patient that in any case you did any discomfort or pain to him or her during the examination, he should notice and inform you. Okay. Introduction by physical exam. As we said, we have to introduce ourselves, wash our hands, and to start with the general examination. Privacy of the patient should be important. Position of the patient should be 45 degree. Explain the examination and get the consent. And it should be also to maintain the privacy of the patient. General inspection. You will inspect the environment. Very important to inspect the environment of the patient. If there is any oxygen devices, if there is any BiPAP or CPAP machine, if the patient is having also a machine for nebulization, inhaler, sputum put in the environment surrounding the patient. Check the patient well-being. Is he comfortable? Is the patient having any respiratory distress? Feature of Cushing syndrome. If the patient is having a feature of Cushing syndrome due to the chronic steroid use, sometimes in the patient with the lung fibrosis and chronic lung disease, patient with bronchial asthma, severe asthma requiring long-standing steroid, patient is cachectic. If there is having a patient COPD or lung cancer, obvious cyanosis, obvious pallor, and jaundice, average body build. This is also very important. Using of accessory muscle. A patient in respiratory distress and is having respiratory rate is high, so you have to notice that by using of accessory muscle. Pursed lip breathing in patient with severe emphysema or chronic bronchitis, COPD, the patient will prevent bronchial wall collapse by keeping lung pressure high in severe airway by pursed lip breathing. If the patient is having stridor also or abnormal sound, and as we mentioned also the environment of the patient. A systemic sign of pulmonary disease clue to the increased work of breathing, nasal flaring, intercostal or supraclavicular retraction, accessory muscle use, pursed lip breathing, disrupted speech, or thoracoabdominal dissociation. This is the scalene muscle and sternocleidomastoid supraclavicular muscle acts as accessory muscle. You have to ask for vital sign of the patient: blood pressure, temperature, respiratory rate, oxygen saturation. طبعا البادي بيلت average body build according to the age and height and weight. Normally if there is 10% above or lower, the average body weight would be considered normal. The appearance, as we mentioned, blue bloater, pink puffer. This is specific for patient with COPD. If the patient is obese and having generalized edema, cyanosis, and puffy eyelid, with fish mouth breathing or pursed lip breathing, this is respiratory failure to the chronic bronchitis. Pink puffer, the patient will slim and cyanosed. Respiratory failure due to the emphysematous changes, severe emphysematous changes. And this is what we mentioned about the blue bloater. The patient is obese, having type 2 respiratory failure, or the new name is hypercapnic respiratory failure with CO2 retention. And this is the pink puffer with a thin, anxious type 2, type 1 respiratory failure secondary to the emphysematous changes. Then we have to examine for the face as a general examination. In the eye, we have to check for the pallor. Ask the patient to look upward and to check for the pallor. And for jaundice, ask the patient to look downward and check for the jaundice. Check for Horner syndrome, unilateral ptosis, meiosis, and hydrosis in ophthalmos. This is very important in case of Pankos tumor or right upper lobe mass. This is what we mentioned also from the anemia, if there is a pallor of the conjunctiva or jaundice. Examining of the nose as a disease related to the respiratory system, redness in the tip, alcoholism, mitral stenosis, but very important is lupus pernio, which is destruction, hypertrophy of the nasal tip. In cases of sarcoidosis, saddle nose in patient with GBA or granulomatosis with polyangiitis, working LNSI in patient with using accessory muscle or respiratory distress and respiratory failure. Mouth, the only site you can examine for central cyanosis is under the tongue. So a patient is having below the tongue, if there is cyanosis, we have to check about congenital heart disease, cor pulmonale, heart failure. Sometimes also in the lips for cyanosis, if there is below the verminal line, you will have also consider it as central cyanosis. This is a patient with central cyanosis. The definition of central cyanosis was common questions during the exam. It's bluish discoloration of the lips and mucous membrane due to the reduced hemoglobin more than 5 gram percent or more than 50 gram per liter. Normally طبعا بيكون ممكن 1 to 2 gram percent of this reduced hemoglobin. طبعا the patient, there is another questions, you cannot detect cyanosis in severe anemia, so you don't say cyanosis with pallor. يعني إذا شفت pallor anemic patient, you don't expect that the patient having enough percentage of reduced hemoglobin to cause cyanosis. Usually طبعا cyanosis oxygen saturation is below the 80%. We have central, we have peripheral cyanosis. Central cyanosis, blood leaving the heart already contain the reduced hemoglobin. Okay, secondary polycythemia, congenital cyanotic heart disease, core pulmonale, Cushing syndrome, renal cell carcinoma, and pulmonary edema, methemoglobin or methemoglobinemia. Peripheral cyanosis, patient you don't have enough amount of reduced hemoglobin, the blood leaving the heart contain a normal or amount reduced of hemoglobin, but because of the stasis of the circulation as it reached the peripheral vessels, the rapid extraction of oxygen or raise the amount of reduced hemoglobin more than 5 gram percent in the periphery. في الحالات اللي بيكون في stages like heart failure, congestive heart failure, peripheral circulatory failure, or in patient with peripheral vascular disease, renal disease, Berger or acrocyanosis, or in the cold weather. How to differentiate between central and peripheral cyanosis? Usually the site. Central cyanosis under the surface of the tongue. البريفرال cyanosis دايما في الاكستريميتي في الهاند والنوز والنيل bed. في السنترال cyanosis the temperature is normal or hot, while in the peripheral cyanosis cold in cold weather. Central cyanosis is usually associated with the clapping congenital heart disease, while it's absent in the peripheral cyanosis. Oxygen saturation usually below than 80% in central cyanosis and normal in the peripheral cyanosis. And if you give oxygen to the patient, it will improve cyanosis due to the lung disease only. And if you give oxygen to the peripheral cyanosis, there will be no improvement. Then we examine the neck for as a part of general examination. We have to concentrate about the GVP, jugular venous pressure, اللي هو checking the GVP pressure in the right internal jugular vein, which is medial to the sternocleidomastoid, and it would give us a changes in the pressure in the right atrium during the cardiac cycle. Very important to check also, there is a specific maneuver for checking the GVP, and by the rural we can also check it from the lateral side and the side, the distance between the GVP and the sternal angle. And we can add also 5 centimeter in order to calculate. Usually above than 3 centimeter can be also considered as raised. The other test also in the neck, we check for the lymph node site, consistency, the border, if it is tender or not, matted in case of TB, and if there is also presence or absence of sinuses. هنا GVP زي ما احنا ملاحظين medial to the sternocleidomastoid, and we check the internal jugular vein, not the external jugular vein. وبنشوف البيشنت لازم طبعا هو put the patient in the 45 degree and we examine this and the distance between the raised GVB and the sternal angle. Then we add for 5 centimeter. In case of congested neck vein and superior vena cava, thrombosis, aortic aneurysm, mediastinal tumor. Usually this is associated with dilated superficial vein in the chest wall. This is a case of dilated superficial vein in anterior chest wall and superior vena cava obstruction. This is congested vein bilaterally, as we noticed here. Lymph node examination. It's important to examine for scalene lymph node and respiratory system. Checking for pancreas tumor, which drain into right side, scalene supraclavicular lymph node. We let the patient to deviate his head slightly to the right side in order to make the maneuver or to relaxing the fascia in order to palpate for supraclavicular lymph node. It's important also to notice that we can examine the lymph node from the posterior position. The doctor should be in the back of the patient, then he start to examine for the anterior triangle lymph node, while the posterior triangle lymph node we examine it while we are sitting in front of the patient. And also we examine for submental, submandibular, preauricular, occipital, anterior and posterior triangle lymph node. Examining of the hand is also important. Yani we have check for nicotine stain, flapping tremor. Ask the patient to outstretch hand, fanning of the finger, and alternatively ask the patient to hold his hand, outstretch and fanning of his finger, and check for the flapping tremor. Flapping tremor denoting there is respiratory failure, hypercapnic respiratory failure, any major organ failure, heart failure, renal failure, liver failure also can result in flapping tremor. If the patient is comatose, you are unable to initiate the patient to let him to outstretch his hand, you can alternatively ask the patient to squeeze your finger, index and middle finger, to maintain his grip for 30 to 60 seconds. The patient with flapping tremor cannot maintain their grip. You have, as we mentioned, also to check for nicotine stain or tar staining, clappings of the finger, palmar erythema in patient with COPD, and suggested CO2 retention. Liver failure also in liver cirrhosis also can be present. Check for the muscle wasting or asymmetrical muscle wasting of the small muscle of the hand, suggested pancreas tumor, compressing the brachial plexus or sympathetic change result in Horner syndrome and muscle unilateral muscle wasting. This is how we examine for asterixis or flapping tremor. And in case of respiratory disease, the patient will have CO2, suggestive of CO2 retention. This is tar staining or nicotine staining in smoker patient. This is finger clubbing. This is stage 4 finger clubbing or drumstick finger clubbing. طبعا definition of clubbing of the finger, it is a bulbous enlargement of the soft tissue of the terminal phalange with which over the curving of the nail bit. There's several degree, first degree, second and third and fourth. First degree fluctuation, increased palatability and softening of the nail bit only. we can examining by palpating the nail bed by the index finger to detect both index finger to detect the softening and yielding the tissue under the nail. Second degree obliteration of the angle of the nail bed detected clinically by Shamroth test. And third degree increase the convexity of the angle أو parrot's peak أو يعني منقار الببغاء. والدرام الفورث ديجري اللي هو درامستيك appearance زي اللي ما احنا شايفينها في الصورة. الفيفث ديجري بعض الأحيان في بعض الكتب بيطلق عليها كمان في fifth degree اللي هو بيكون pulmonary osteoarthropathy، الناس اللي بيكون عندهم في ال long standing disease or sometimes in case of lung cancer widening and thickening of the end of the long bone بيسموها pulmonary osteoarthropathy. هنا موجودة اللي هي Shamroth windows absent. Common questions: what is the cause of unilateral finger clubbing? Cervical rib, pancreas tumor, aortic aneurysm, infantile cortication of aorta. If there is only clubbing in the lower limb only أو بيسموها differential clubbing بيكون دايما في الأيزنمنجر patent ductus arteriosus or infantile cortication of the aorta. Reversible clubbing: what is the causes of reversible clubbing? Mesothelioma, fibrous type. The patient will have a subside of the clubbing after surgical removal of the tumor. As we noticed here, the commonest cause of clubbing is pulmonary cause, thoracic causes. 70% account يعني lung cancer, suppurative lung disease, bronchiectasis, lung abscess, empyema, it is inflammation or presence of infected pleural effusion in the pleural cavity, cystic fibrosis. كلها هذه تحت بند اللي هو chronic suppurative lung disease. الميزوثيليوما, lung tumor, fibroma. Pulmonary fibrosis also a common cause for finger clubbing. وفي برضه cardiovascular cause اللي هي cyanotic congenital heart disease, infective endocarditis, arteriovenous shunt or aneurysm. والgastrointestinal cause of finger clubbing, cirrhosis, inflammatory bowel disease, celiac disease, and the other like thyrotoxicosis. Significant of a clubbing طبعا أكيد في significant. We have to check for malignancy, primary or secondary, suppurative lung disease, interstitial lung disease, lung fibrosis. Then we check for the lower limb. Lower limb دايما بنخليها as a part of general examination. Check for edema. You have to face the patient at the end of the bed, eye-to-eye contact. If the patient is having pain or not, then you press for 10 seconds, 15 seconds for pitting edema. If it is unilateral, bilateral, pitting or non-pitting, also is very important to comment on that. هنا زي ما احنا ملاحظين يعني في pitting edema. Well, this is unilateral right leg swelling suggested of could be deep venous thrombosis or inflammation or rupture Baker cyst. The lower limb also related examination ممكن examine for erythemanodosum in the chins of in the anterior border of the leg. If there is tender or painful lesion like this associated with sarcoidosis. Extrapulmonary finding of systemic disease, sometimes during the hand. This is a rare Gottron sign and dermatomyositis, heliotrope rash, في الeye or mechanics hand cracking or fissuring of the hand. This is all result in give us an idea that we are dealing with connective tissue disease of the patient, like antisynthetase syndrome, which is an inflammatory muscle disease, interstitial lung disease, Raynaud phenomena, arthritis, cutaneous manifestation, and positivity of the anti-Jo1 antibody. General appearance also by this patient. This patient is having obstructive sleep apnea, overweight, large collar size, hypertension, micrognathia, cyanosis, sign sometimes we found core pulmonale, sign of core pulmonale, septal deviation, or sometimes we can find a CPAP equipment, although here non-invasive ventilator beside the patient bed. Also we need to, this is also diagram for diagnostic approach for a clinical patient. And patient with fever, we can check for infection, eosinophilic pneumonia, drug, vasculitis, rash في الساركيدوزس, erythemanodosum في الconnective tissue disease, البيك نوز في السكليروديرما في الكيراتوكونجكتيفايتس سيكا, Sjogren, uveitis, Raynaud phenomena, lymphadenopathy. This is also a systemic sign of diffuse parenchymal lung disease.